Welcome, and thank you for taking the time to join us today. I'm Roberta McLean, Project Coordinator, Practice and Policy at the Ontario Physiotherapy Association, also known as the OPA.
And I'm Sherry Hughes, Associate Registrar for Practice at the College of Physiotherapists, or the College for short.
The College and the OPA are really excited to be working together to help guide physiotherapists through the transition in the way that publicly funded physiotherapy is delivered in Ontario. The changes introduced by the Ministry of Health and Long-Term Care came into effect in August 2013 and affect the care delivery models in long-term care, retirement homes, and the community. This is the first of 3 webinars that we will be presenting. Today's webinar will focus on physiotherapy care delivered in publicly funded physiotherapy clinics. To be a community physiotherapy clinic and deliver publicly funded physiotherapy, you must have a signed contract with the Ministry of Health and Long-Term Care.
Our goal today is to provide practical advice and information that physiotherapists working in community clinics can apply right away. The first 30 minutes of this session will provide practical advice on real-life scenarios familiar to many of you. The last 30 minutes of the session will be devoted to answering your questions. Many of you have submitted questions in advance, and we thank you for taking the time to do so. If at any point during the presentation you have a question, please submit it through the question box on your computer screen, and I see that a couple of people have done so already. If we can't get to your questions during the hour, don't worry. We will be posting responses on the OPA and college websites, along with an archived copy of this webinar. Before I introduce our panel of speakers, I'd like to ask you to complete our online poll. How confident are you that you understand and can apply the expectations of the new funding model in your practice? While you answer that question, I also want to point out that if you experience any technical difficulties at any point during the webinar, please click on the Help button under the video portion on your computer screen. Now for our panel. We have Shelley Martin, the College Practice Advisor, Dorianne Sauvé, the Chief Executive Officer of the OPA, Shenda Tanchak, the College Registrar, and Jennifer Holstein, Director of Practice and Member Services at the OPA. I'm going to hand it over to Shenda to get us started.
Thanks, Sherry, and welcome, everybody. I'd like to just add my thanks. We're grateful that you're with us tonight. Before we get into the specifics, I think it would be helpful for all of you to know how the College and Association differ and where we're similar, and how it is that we came to be working together on this particular webinar. As I'm sure you know, the college's job is mostly about protecting the public, and we do that by regulating the practice of physios. We regulate physiotherapists by making sure that only qualified physiotherapists can practice in Ontario, and that once you're in, you maintain competence throughout your career and adhere to professional standards. If we receive a complaint or concern about you, it's our obligation under the law to investigate it. We take these responsibilities really seriously because our mandate is regulating physiotherapists in the public interest.
The Ontario Physiotherapy Association, OPA, represents the interests of its members. It does so by providing advocacy, professional development, and career support services. These services help physiotherapists provide quality care, which also contributes to patient safety. The interests of the profession and the interests of the public often overlap. What is good for the public is often good for physiotherapists too. Helping physiotherapists understand and practice within the new funding model is a great example of this.
We understand that the funding model changes means some substantial changes in physiotherapy practice. And both of our organizations have been hearing lots of questions and understanding that there's quite a lot of confusion out there. We're hoping that today's webinar is going to help clear some of that up. We know that this transition period isn't easy for you. We're going to do our best to answer your questions. But we also need to reinforce to you that the changes in the funding model don't change your professional obligations to your patients. The shift is just about the way clinics get funded or how PTs get paid for the care they provide. So just a really brief overview. The community clinics now receive funding based on the number of episodes of care that they have promised to provide. Let's say your clinic gets funding for 10 episodes of care. That might be 5 patients who each get 2 episodes of care, or it may be 1 episode of care each for 10 patients. And while the funding model was based on $312 per episode of care, that number was only a calculation used to figure out the global funding that each clinic would get. It was never intended to be $312 per patient. The system looks an awful lot like the global funding that hospitals receive. Some of your patients are going to need more visits, and some of them are going to need fewer. And what we're confident about is that it's all going to come out in the end.
Thanks for that overview. So let's get started with our discussion about providing care in a community clinic under the episode of care. For your reference, the information we provide is based on material developed by the Ministry of Health and is available on their website. Our goal is to apply the information to real-life situations, as well as questions and concerns. So we'll begin with a couple of scenarios. The first illustrates who qualifies for an episode of care.
Thanks, Jennifer. So Rebecca is 62. She arrived at your clinic after an overnight admission to hospital following to investigate a concussion and severe knee pain after she had a fall. Rebecca would like to receive physiotherapy care and heard your clinic does provide publicly funded services. Does she qualify under this new funding model? Tiana is 16 and she's done something to her knee. She's in pain, so her mother brought her to your clinic for treatment. Tiana's mother's not sure if Tiana qualifies for publicly funded care because she actually heard that only seniors qualify for this service. Does her daughter qualify for an episode of care? Who can access publicly funded services under the new funding model? Does 62-year-old Rebecca qualify? What about 16-year-old Tiana? The answer is they both qualify, provided they have a referral from a physician or a nurse practitioner. Patients who previously qualified under for publicly funded services at a designated physiotherapy clinic continue to qualify under this new system. Although Rebecca is under the age of 65, she qualifies for publicly funded care because she spent a night in hospital for treatment for services related to her accident. Tiana qualifies because she is under the age of 19.
So now that we've talked about who qualifies, let's move on to how do we manage patients with multiple issues. We'll start with Bruce. Bruce is an active senior. He's 75 and he's been having problems with his knees and wrists because of arthritis. He really wants to be able to curl with his friends this winter. What do? Do you treat his wrists or his knees? What constitutes one episode of care? What exactly is an episode of care, and is it true that patients only can access 8 or 12 visits within an episode of care? First off, under the new model, block funding is provided to a clinic to provide physiotherapy services to a defined number of episode of care for patients who meet the eligibility requirement. This funding covers the entire episode of care rather than individual visit. In this scenario, Bruce's episode of care relates to arthritis and includes both his knee and wrist pain. Funding for the episode of care includes assessment, diagnosis, treatment, and a summary report to the referring physician or nurse practitioner. Therapeutic goals should be identified and discussed with Bruce. His progress measured using standardized outcome measures, and his treatment plan documented. There are no preset maximum limits to the number of visits an eligible patient can receive under an episode of care. The number, frequency, and duration of visits must be reasonable for the treatment of the condition as determined by the physiotherapist using their professional judgment. As part of the assessment, you and Bruce, working together, will identify therapeutic goals. You will select a standardized outcome measure from the list provided by the ministry and by which progress will be measured. Treatment should continue until the goals have been met or The goals can be achieved through self-management programs, or the goals can be achieved through exercise, falls prevention, activation, or other programs available in the community. So from your history and assessment, you know that Bruce has arthritis, which is a chronic condition. This is not the first time Bruce has had pain in these areas. You talk to Bruce about self-management techniques for pain and provide home exercises to address strength and mobility. You schedule Bruce for a few more sessions to reduce the acute pain and make sure he's able to carry out his home program. Once Bruce has met the identified treatment goals, he can be discharged. You will want to teach Bruce how he can do some self-management and provide him also with community resource information for programs such as those available in a local community center or through the Arthritis Society that can help him manage his arthritis. Should Bruce experience another acute flare-up after he's been discharged, he can return for a second episode of care as long as he comes with a referral from his physician or nurse practitioner. Let's look at another scenario. Oops, over there.
Sure, let's talk about John. John is 14. He was trying a new trick on his skateboard and took a jump the wrong way. He badly sprained his ankle and fractured his elbow in the process. John's elbow is in a cast for the next several weeks. He's in pain, and you know he qualifies for treatment since he's under 19, but you're wondering how to best address his needs. This might be a case for 2 subsequent episodes of care. One now to deal with his ankle injury and one later when his cast is removed. A patient cannot receive 2 episodes of care at the same time, but can receive them one after another. Your approach will likely be similar to the one taken with Bruce, which was to manage the acute pain and provide home exercises to improve range and strength of the sprained ankle. This may seem like common sense, but incorporating best practices and striving to get people better faster is critical to succeeding in this new model. So you investigate the lower extremity functional score, or LEFS, as an outcome measure to track John's progress. Once you've completed John's treatment for the ankle and completed a finishing LEFS score to demonstrate he met his therapeutic goals, John can be discharged from care. Later, when the cast is removed, if John requires additional care for the elbow, you can schedule John for a new episode of care for treatment of the elbow. If John doesn't have a referral for physiotherapy after his cast removal, he'll have to go back to his physician or nurse practitioner to get a new referral. John is young, healthy, and active. Chances are he'll recover quickly and without any complications. But there will be other circumstances where a more complex patient arrives at your door. For example, a patient with multiple sclerosis who has range of motion, tone, strength, balance, and endurance problems. You may be wondering how you can best provide care to this type of patient within the new funding envelope. It's important to remember that the physiotherapist is not intended to be the only care provider in the health system. Other resources and supports exist and should be accessed. You'll need to do some legwork up front to discover what resources are available for patients in your area so that you can advise them appropriately. There will be more discussion about this a little bit later, so let's move on.
Let's talk about managing the number of episodes of care. You run ABC Physio Clinic and you're really busy with the demand for community-funded physiotherapy care. You don't want to turn anybody away. But what happens if you admit so many patients in the first few months that you use up all the episodes of care that you're contracted with the government to provide? Can you refuse to take on any more publicly funded patients? Should you start a waiting list? Can you refer any new patients to another clinic? Community clinic owners who have an agreement with the ministry have to make sure that they manage their business practices in a way that they spread the care out throughout the whole year. As a clinic owner, that means that you're going to need to calculate how many clients you can accept every month to make sure that it's spread out for the year. If your clinic has slow and busy times, you can adjust your scheduling accordingly. However, if you reach the point where no more patients can be accommodated during a particular month, you can offer to put patients on a waiting list to receive services. Now, this is going to be a shift in practice for some of you, and we can talk more about waiting lists in a minute. The most important thing is to establish guidelines that are going to prioritize access, who gets access to care. It's going to be reasonable to prioritize patients based on their level of need. And of course, as a professional, you're going to exercise your clinical judgment to understand who needs care faster. If you haven't got any more space in your clinic for publicly funded patients, and the wait list is long, your patients are going to be really grateful if you can refer them to another clinic, a community healthcare center, or coming soon, a family health team.
Great, thanks, Chanda. Let's talk about Mrs. Jones. She's 75 and she's already had 2 episodes of care for recurrent knee pain. Just recently, she called to tell you that she fell and her knee is painful again. She's now having difficulty with pain and unsteadiness. Can you treat Mrs. Jones for a 3rd episode of care within the same year? Yes, she does qualify for a 3rd episode of care, but she will need a new referral. Another consideration is that Mrs. Jones' knee pain has become chronic, and the fall, combined with the reported unsteadiness, indicates that Mrs. Jones may need to be referred to a falls prevention program. You recognize that physiotherapy care can't go on indefinitely, so you may want to lengthen the time between visits and focus on self-management. This will help Mrs. Jones reach her therapy goals.
So the next scenario we're going to talk about is what about delivering 2 episodes of care at the same time? Let's go back to my friend Bruce, our senior with arthritic knees and wrists, who's ready to start his curling season. It was reasonable to treat Bruce's arthritis under 1 episode of care. He had a single condition, diagnosis arthritis, even though he had symptoms at multiple sites. But what about Mary, who has long-standing neck pain because of poor posture? I'm going to sit up straighter. And degenerative changes, but more recently fell and broke her wrist. Can you treat Mary's neck and wrist at the same time using 2 episodes of care? The ministry has been very clear in this area. A patient cannot access more than 1 episode of care at the same time. You also can't refuse to treat Mary just because her needs are complex. You can teach, I think the first thing to remember is to be able to prioritize issues and problems, what needs to be addressed first. You can teach postural correction and pain management strategies for her neck so that she can self-manage those symptoms while you focus on her most acute problem, her wrist. You will need to set goals, provide treatment until the goals are reached, or can be managed through a self-management program or through exercise or other activation programs that might be available in the community. Mary will then need another referral to address her secondary problem, which is the neck pain. Don't forget about accessing other community resources that can help Mary. The Ministry of Health is currently developing a list of community resources to help get you started. Please continue to check with their website. You shouldn't be the only care provider when the needs are complex.
So what about managing dual funding streams at the same clinic location? Most community clinics don't rely solely on ministry funding, and their business model will include accepting other payment streams like extended health benefits insurance and private pay as well. In fact, some patients may have access to several funding streams at the same time. Physiotherapists are not restricted, obviously, from continuing to provide treatment to other clients based on other funding models. Community clinics can provide services to patients paying out of pocket through auto insurance benefits, extended health benefits, WSIB, and so on. But how do you manage the perceptions of patients and move patients from one stream to another? You need to be prepared to devote some energy, care, and attention to making sure patients, family members, and other health professionals understand the new model and what it means for them. If a patient does not meet eligibility criteria or no longer needs physiotherapy services under an episode of care, they can be offered the option to receive care under another funding stream. However, discharge from an episode of care should only occur when the therapeutic goals identified in the treatment plan, those goals that you came up with together, you and the patient, when those treatment plan goals have been met, or when the goals can be achieved through self-management or through an exercise, falls prevention program, activation, or any other program. So what if patients qualify for an episode of care, but they also have access to extended health benefits? Can clinics establish a policy so patients with extended benefits have to use up their coverage for physiotherapy services prior to accessing publicly funded care? And the answer is no. Clinics cannot impose such a policy. If an individual is eligible for an episode of care and there is no waiting list, service should be provided. If there is a waiting list, and we've discussed some of the reasons that those would be developed already, patients may be given choice as to which funding model to access. The clinic is not permitted to charge or bill the patient or any other entity, for instance, Extended Health, for the physiotherapy services provided under an episode of care.
Liz is 67, and she has benefits under her husband's extended benefits plan. Recently, she's come to your clinic to receive care for her low back pain. Liz qualifies for publicly funded care, however, you know she has insurance. You tell Liz that she can have 4 visits of publicly funded care, but then she has to switch over to her extended benefits plan. Is this approach okay? No, it's not. Eligible patients must receive a full course of care for a specific diagnosis. Care is not limited to a certain number of visits, as we've already mentioned. Treatment must continue until Liz has reached her therapeutic goals, or when the goals can be achieved through self-management or through an exercise, falls prevention, activation, or other program, not when you decide that you're no longer making money to provide the treatment. It is possible to offer patients choice. Waiting lists may be necessary, and patients ought to understand their options. Transparency in communicating this is so important. Consider carefully how you will set up your waiting list and how you will prioritize patients to receive care. You will want to be careful to avoid discrimination or the perception of steering patients. Allowing patients to make an informed decision is always appropriate. Documenting your waitlist criteria and establishing policies on how you will manage the waitlist will make it easier to justify your decisions if need be. The new funding model represents a change, and it's going to take time for everyone to gain a better understanding of how things work. Patients will also need to understand what's new or what's different.
Thanks, Shelley. We're going to get to questions in a few minutes, and I think that Sherry mentioned at the very beginning that lots of you had sent questions in, and I'm now looking across the room at Sherry and Roberta, who are writing feverishly and whispering to each other, so I assume that lots of you are sending questions in. I don't think we're going to be able to answer all of your questions, so I want to remind you that if we don't get to you, make sure that you check the website after, and if we don't know the answer to your questions, we'll find it out, that's our job, and we'll post the answers. And if I sound scared, it's because I'm a little scared. But anyway, let's go on to the question, to recap some of the information that we know, because we already talked about it. What we know is that there are lots of changes to how you're going to have to run your practice that have arisen because of the new funding model. We know it's scary and we know it's hard, and we're doing our best to get the answers for you and to be of assistance. So please feel free to contact us. The easy part is knowing that the patient population hasn't changed. The people who used to qualify for publicly funded care still qualify for publicly funded care. Under the new model, funding's provided to clinics based on the number of episodes of care that they have contracted to provide. The focus is on achieving outcomes that have been jointly agreed to following patient's assessment. Funding for each episode of care includes assessment, diagnosis, treatment, and that discharge report that you're going to provide back to the referral source. Patients can access only 1 episode of care at a time, but as long as they get a new referral, they can come back for as many episodes of care as they need and you have room for in your clinic. The episode of care ends not when a certain number of visits have been met, but when the treatment goals have been met. And the PT determines through assessment that no further treatment's required, or that ongoing improvement can continue through a self-managed care program or through other resources that are maybe available in the community. Physios can't refuse to take on eligible publicly funded patients, but they are able to use waitlists to manage the resources over the course of a year. When you're using waitlists, you're going to need to have clear and transparent guidelines about how you prioritize the patients that you'll serve. Patients can't be required to use up extended health care benefits before they can access publicly funded services, but you can offer them a choice. If you have a waitlist on the publicly funded side, they may choose to use their health benefits or pay out of pocket. As long as you've provided them with clear information, let it be the patient's choice. And PTs are not restricted from continuing to provide treatments in their clinic to patients who receive care through other funding models. Dorianne?
Thanks, Jenda. The college and the association are working together to make this transition easier for the public and for physiotherapists. Please continue to visit our websites and the Ministry of Health website for further updates and additional resources. I will turn back to our frantically working moderators, Sherry and Roberta, who will be compiling your questions.
Thanks, Dorianne. The first question is one that was pre-submitted, and so again, thank you to those who submitted your questions in advance. I'm going to ask Shelley to respond to this first question. Shelley, what will be the role of support personnel, or PTAs, to deliver physiotherapy services to qualified patients under the new model?
Thank you, Sherry. In order for physiotherapy services to be funded under an episode of care, the services must be provided in accordance with a written treatment plan for an episode of care and be of the level of complexity that requires the knowledge, skills, and judgment of a physiotherapist to perform, and must be performed by either the physiotherapist or their assistant who has been assigned the services. The physiotherapist is expected to meet the performance expectations of the standard and guide to physiotherapists working with physiotherapist support personnel. For example, the physiotherapist must ensure that the patient is reassessed periodically to determine if the role of the assistant has changed over time or if the needs of the patients have changed. As well, the physiotherapist shouldn't assign any aspect of care that has an evaluation component that will immediately influence the treatment program. For more information about working with assistants, I would recommend that you visit the college's website and have a look at the standard and guide for physiotherapists working with physiotherapist support personnel.
Thanks, Shelley. Jennifer, I'm going to direct this next question to you. Is there any inclusion and exclusion criteria to be in a physiotherapy program in long-term care?
So the short answer is sort of. There is a definition of funded physiotherapy services in long-term care, and this is something that, because this is a different sector, the long-term care sector, and today we're talking about the community clinic program, we will be addressing the long-term care issues in another webinar. But the Ontario Physiotherapy Association and the Ministry of Health and Long-Term Care have both posted on their website the definition of funded physiotherapy services in long-term care. So I would encourage anyone who's a little bit curious about that right this very moment to go check those out.
Thanks, Jen. Dorianne, this one's for you, and there's two parts to this question. And the first one is, have all the clinics that have applied for funding received approval from the Ministry of Health to provide publicly funded care? And the second part is, what is the expectation for these community physiotherapy clinics to start up once approval's been received?
Okay. We've been checking with the ministry quite regularly to find out the status of where the rollout for the new clinics are at. And the most recent information we have, probably over the last couple of days, is that the rollout is taking place basically in two stages. With certain LHINs, particularly those that didn't have access to publicly funded services in the past, they've been prioritized. But at this point, the majority of clinics in all of the LHINs, with the exception of Central East, Central, and Champlain, have at least been contacted. The ministry is currently working to move as many of the funding agreements through the sign-off process or funding approval process stage as quickly as possible. This funding approval process takes about 6 to 8 weeks to complete. So it's expected that the clinics in LHINs that have not received any notification should be hearing soon. And I believe that the clinics in Champlain should be hearing sometime next week. But basically, the expectation is once you've received the contract, that then there is a period of time between receiving the contract, signing the contract, and then the startup of business.
Thanks, Dorianne. The next question that we have here, I'm going to ask Shenda if she'll answer it. The question reads, how do I treat a patient with multiple complaints under this new funding model?
I got this one. An episode of care it's one discrete group of treatment, time-limited, goal-oriented physiotherapy services provided to a specific patient, and you can't have two of them at the same time. So if I present to you with multiple conditions related to a single diagnosis, then you can treat my multiple sites concurrently within one episode of care. But if I show up with unrelated problems and you diagnose them as unrelated, so I have a hurt elbow from my skateboarding accident, and I also have a soft tissue injury to my lower back, and they're not related to each other, they have to be treated as separate episodes of care. So you, not me, because I don't have that kind of professional judgment, would determine which I needed treatment for first, and then send me to get a referral for the second episode of care.
Thanks, Shenda. I have another two-part question. This time I'm going to ask Shelley to respond. Shelley, why is the Ministry of Health only covering acute episodes in the community physiotherapy clinics? And what if a patient requires more of a maintenance program that cannot be provided through community classes or home exercise programs?
Good questions. So the new funding system is focused on time-limited and goal-oriented episodes of care, but that doesn't mean it isn't helpful to assisting those with chronic illnesses or conditions, similar to programs that focus on these conditions. The new system provides for episodes of care to deal with flare-ups, which require the one-on-one attention of the physiotherapist in the clinic while working towards discharge, towards home brace programs, self-management, access to community support programs for the times between the flare-ups. The clinics will need to be very aware of complementary programming that can help these patients manage from episode to episode. Additionally, assuming that the maintenance of the patient requires the intervention of a physiotherapist and the patient's needs cannot be met in the community, it is important to note that an episode of care has no specific time limit. You may elect to see the patient intermittently over a course of a longer period of time.
Great. I have another pre-submitted question here, and I'm going to ask that Jennifer answer it. It says, am I allowed to see a patient for one-on-one physiotherapy while I also have them in an exercise class?
Thanks, Roberta. This has actually been a fairly popular question at the OPA office as well, so we've answered this a few times, but also I'm not exactly sure if you're referring to the community clinic model or within the long-term care model, but they both approach it in the same way. Community exercise classes are completely separate to physiotherapy services. And they're funded completely differently. They're considered to be completely separate programs. The community exercise programs are available to any resident of Ontario without a physician referral. Anyone can attend them. If a patient is already participating in a community exercise program, but it's your professional opinion as a physiotherapist that they also require treatment by a physiotherapist and they have a referral for physiotherapy services from their physician or nurse practitioner, there's nothing wrong with them accessing both programs. Again, this is also true in the long-term care setting, as true as it is of the community clinic setting. As an aside, we understand that some people are a little concerned with how they're going to refer out to the community exercise programs. Each local health integration network is starting to list the available exercise programs in those communities and keeping them up to date as everything happens and as new programs come online. So I would encourage everyone to also keep track of their local health integration network and what additional community programs are being developed in those areas.
Thanks, Jen. Your turn, Dorian. If a community physiotherapy clinic uses specialized equipment like taping and acupuncture, is there a way to recoup cost for those supplies?
If you're using those pieces of equipment as part of your in-clinic treatment, then that's considered the cost of doing business. It's part and parcel of the episode of care. I think the exception to that is if somebody, if the patient is taking a piece of equipment, either renting a TENS machine or wishes to purchase some TheraBand in order to complete their home program, and then they are taking it home for personal use, then that can be charged as a separate thing from the episode of care, and you can either bill extended health benefits or have the patient self-pay.
Okay, next up, I have a scenario, and I'm going to ask that Shenda answer it. It reads, a community physiotherapy clinic has told a patient that there are a maximum of 12 visits and that the patient will have to pay to continue treatment. Is this information accurate?
It's not. And we've been getting calls from patients and family members about this concern. I can understand where the confusion arose, and I think it comes up because of the way the funding model is calculated based on the $312 figure. But as I said at the outset, that was actually only for the sort of background calculations that would let you figure out your business model. When you're setting up your clinic and figuring out how many patients you can take on and what the distribution of new patients is going to be every month, you're going to have that information in the background. But that's not information that's going to have an impact on each patient and the number of visits that they get with you. And this, we understand, is a shift, because maybe in the past you were accustomed to providing patients, or some patients anyway, care, let's say 3 times a week for an extended period of time. You're not going to be able to offer that kind of treatment program under this funding model unless you're that rare person who really wants to work for free. And nobody's expecting that from you. But I'd like to remind you, too, that for many of you, this new situation, this $312 concept, isn't unique. You've been treating patients with funding limits under extended healthcare programs before. And what you needed to do then is something that Jen said earlier. You needed to incorporate best practices, and you needed to strive to get people better faster. And that's what you're going to need to do under the new funding model. You're going to need to look at the number of visits the patient's going to need at the time that you diagnose and assess them and set up the treatment plan. And maybe it's going to look like, while at the beginning, while they're in their most acute stage, you're going to see them more frequently. And you're going to teach them how to manage their care at home. You're going to help them access other resources in the community. And as they get better, maybe you're going to spread those visits out. You're going to need to think about the most efficient use of the valuable physiotherapy care. It's a renewable resource, but it's not an unlimited resource.
Thanks, Shenda. Jen, your turn. I'm going to pick on you. Someone is asking whether it's true that seniors can be asked to use up their extended health benefits before they obtain publicly funded care.
It is not true. Although I can understand where the question comes from as well. Any private practitioners who have worked in the auto insurance system, for instance, know that the auto insurer is always the last payer. So that means that if you have other extended health benefits or any other benefits really that are available to you, you have to access those first before the auto insurer will pay. This is not the case for the episodes of care through the funding through the Ministry of Health. But it is important to remember, again, we'll go back to the point that patients do have the ability still to choose which method of payment that they want to access. but you need to remember that the communications to the patient about their available options need to include all information they need to make an informed decision. This information could include the guidelines that you use to determine your prioritization on your waiting list, why their condition has been assigned a particular priority if they are in fact on a wait list, and that should they choose to access care through their extended health benefits or self-pay, that they can do so at your clinic or at other private clinics in the area that don't have a contract to provide publicly funded services. Again, it's providing that patient choice. If you complete an episode of care and have discharged the patient, determining that, for instance, an ongoing self-managed home program and activity programs in the community would be appropriate, but the patient wants to continue treatment in your facility, they can have the option to do so outside of the episode of care funding and using other methods of payment, including extended health benefits or self-pay.
Great. Thank you, Jen. We have another question here about payments, and I'm going to ask that Shelley answer it. It says, a patient comes to a community physiotherapy clinic after a total knee replacement. Can you place them on a wait list but offer to treat them privately right away?
I think the first question that the physiotherapist needs to ask is, do I have a full caseload? If there is no wait list, you would treat this patient right away. The use of a wait list must be guided by an open and transparent prioritization guideline that applies to all patients who qualify for publicly funded care. If there is a wait list, you could then offer the patient to have privately funded care.
Thanks, Shelley. So just to clarify, the question about whether you have a wait list or not comes before the question about whether or not they have the ability to pay privately.
Exactly.
Thanks. Dorianne, I have a question for you, and it relates to specialty services. So the person wants to know if a specialty service like pelvic floor physiotherapy would be covered under these new community physiotherapy clinics.
So yes, it would. The community clinic system doesn't base coverage on specific interventions or modalities, but rather on the overall services and expertise of a physiotherapist. So yes, pelvic floor physiotherapy would be included for patients who qualify. I think the idea of specialty treatment also brings up another point in my mind, is that you really do need to be aware what other programs are available in your area. So if you have patients with something like COPD or stroke or other conditions which would benefit from something like a multidisciplinary clinic or an outpatient interdisciplinary stroke program, or even a geriatric day hospital, should your patients' needs be best served in these kind of programs, it's okay to refer them back to their physician so that the physician can help them navigate into that part of the system. It's really what's best interest of your patients in terms of meeting their needs.
Thanks, Dorianne. Next up, we have a question that speaks to referrals, and I'm wondering if Shenda, you'll answer it. It says, when transitioning a client from home care to a community physiotherapy clinic, does the client have to get a new signed referral, or is the referral provided for home care physio sufficient?
It's a good question, because I'm sure that it seems obvious to you that somebody who needed home care now needs ongoing care in the clinic. But I think it might be helpful if you think about the referral as the ticket to entry to the publicly funded system. So even if it just seems like paperwork, every time you are offering a patient a new episode of care, you're going to need a new referral.
Thanks, Shenda. Dorianne, back to you. With these changes to the funding system, do you expect to see more expansion for rehab in other sectors of the health system?
Wow. Actually, I don't think that we've had so much discussion about rehabilitation in the provincial health system in a really long time. And definitely there's a lot of conversations happening. According to the Minister and the Ministry of Health and Long-Term Care, with this reform, there was definitely an expansion of the number of clinics that will be offering services in Ontario, publicly funded physiotherapy services. And a lot of that was to finally address, I think, the geographic gaps that we were seeing, where we had clinics located only in certain areas of the province. And so definitely the goal was to look at expansion and getting services to more areas. But we're also seeing a lot more different and interesting initiatives happening out there in the community right now for rehabilitation. And I think some of that is the investment we're seeing for physiotherapy in primary care. So not only are physiotherapists now on the list of eligible professions that can be part of family health teams or nurse practitioner-led clinics or community health centers or AHACs, we're also seeing physiotherapists included in pilot projects like the most recent one announced around low back pain. So that's kind of all exciting. We're also hearing a lot about conversations that are happening about rehabilitation in general in Ontario and looking at the system across the full continuum. So whether that be home care or outpatient services from a hospital or the distribution of rehabilitation inpatient beds. So those conversations are happening, and really looking at that investment as part of the continuum of care seems to be a conversation that's happening more and more. So I'm expecting to see a lot more developments over the next few years.
Thanks very much, Dorianne. For our next question, I believe that this one was addressed during the presentation, but I think that it is really important. So Jennifer, I'm just wondering if you'll go over it one more time. It asks, what are the criteria to discharge patients in Ncpcs according to this new funding model?
Okay. So you have the goals that you have set when the patient first comes to see you, the treatment goals that you have established in conjunction with the patient and according to the diagnosis you've come up with. So the discharge should happen either when you've met those therapeutic goals, those objectives that you've come up with and identified in the treatment plan. If you have decided that equivalent gains to reach those goals could be achieved out in the community through other programs, including exercise programs, falls prevention, activation, etc. Or if you decide that no further gains are actually achievable with continued physiotherapy treatment.
Thanks, Jen.
Pleasure.
Shelley, I have the easiest question so far for you of the night, so it might will this webinar be available at another time or on the website after it's been broadcast?
Yes, absolutely. This webinar is going to be posted afterwards on the OPA as well as the college's websites.
Thanks, Shelley. Shanda, I'm going to direct this next one to you, and I'm going to read it out as the physiotherapist asked it. So they said, my question refers to how we should deal with patients who have been paying privately up until now, but then realize that they qualify for an episode of care, and therefore they've been paying privately when they were not required to. Obviously, we want to be fair to everyone, and I want to equip my admin staff on how to address these questions and concerns when they arise.
Thanks, Roberta. That's a tricky one. I guess the first thing I'm going to say is, wow, be nice to your admin staff, because this is going to require some diplomacy. Although it's a little bit hard for me to figure out exactly how this situation is different than it was a year ago before the funding change, because the patients who used to be eligible for publicly funded care are the same patients who are today. So if your clinic previously found itself in this situation, then you may have dealt with this before. But if what you mean is your clinic previously wasn't one of the ones that could offer publicly funded care, so patients who used to come to you privately are now in a position to receive publicly funded care, then that's all you need to say to them, is that it's perfectly okay to transition to publicly funded care at this point, but don't forget that referral letter. If you were publicly funded before and your patients were receiving publicly funded, then they're still in the position under the new funding model to transition into the public funding again. So I hope that answers the question.
I think it does.
Great.
Shelley, I have a question for you. Are clinics required to use standardized outcome measures as part of an episode of care?
I believe the Ministry of Health has identified certain outcome measures, And I believe they were identified in the contractual agreements for the clinics that have received funding for the episodes of care. If you don't have access to this list at your clinic, I'm sure it's either available on the ministry website or you could contact the Ministry of Health.
Thank you.
Sorry, just to double up on that one.
Perfect.
It will actually be a requirement of the episode of care to, and I think we did go over this, but I think it's important to say again, it will be important, a requirement of the episode of care that a baseline outcome measure is taken at the initial assessment, and that the outcome measure is done again at the end of the episode, and these outcome measures will actually be reported back as part of the reporting requirements of the clinic to the Ministry of Health.
Thanks, Jen. Dorianne, I have a question for you. Someone just asked, will clinics hear why they were not successful so that they can make improvements to subsequent applications?
At this point in time, our belief or our understanding with the ministry is that all clinics will be notified whether or not they were successful. That was the understanding we had with the ministry, or at least from what they were telling us. I'm not sure how much feedback they provide, and a lot of the choice has not which clinic was chosen to be to receive it or not receive it doesn't have is more in relation to the location of the clinic, where in the LHIN, and where did the LHIN determine that particular services were needed. So the reflection is probably much more of a decision based on the LHIN analysis of where the clinics needed to be located versus one clinic over another. But at this point in time, I don't have information as to what other kind of feedback they would receive, but we've been stressing with them the importance of getting back to everybody who took the time to put in an application.
Thank you. I think you answered a couple of other questions that were on the list, so that's perfect. So I appreciate that. Shenda, this one will be for you. And I think you probably answered it in one of your earlier questions, but again, as Roberta said earlier, it's sometimes worthwhile repeating these things. Slightly different spin on it. What if you're the only clinic in town and you run out of visits?
You run out of funding for episodes of care. I guess I think it depends on how much of the year is left. Because if there's months and months left and you've managed your patient load poorly, inadequately, what you're going to need to be thinking about is the likelihood of the contractual renewal and that kind of thing. So there's a window for which a waiting list is appropriate, and then there's a period of time where it's just too long. It's hard to say up front, and I get that this isn't a very satisfactory answer. But if I were running the business, I would be looking at my relationship with the Ministry of Health and my ability to fulfill that piece of my contractual obligation, which was to provide care for all 12 months.
I think in our conversations with the ministry around that, because we definitely brought up that issue, and they responded exactly the way that what Shenda just mentioned. But I think it's also important that if you're coming, like if you are close to the end of the month or close to the end of the year and you are running out, it's to have that conversation with the ministry ahead of time. Mm-hmm. So if you're getting into your last quarter of your funding year and you know that your episodes of care are not, you don't have very many left, that's the time to have a conversation with the ministry. Show them what you've done, show them what you've done in terms of waitlist management, show them what you've done in terms of prioritization, and interact with them about whether or not that wasn't, is there other funding available towards the end of the funding year to look at additional funding for that. If you've managed it well and it's close to the end of the year and you've done everything you can to appropriately manage your episodes of care, that's a conversation they're wanting to have with you. So I think that's an important point to make, because what we don't want to see is, again, it's a new system. They've done estimates of episodes of care for the expansion, and they need to hear some feedback as to what the demand actually was and how that's been managed and whether or not there needs to be an adjustment as we go forward on that. So
it's another reason, isn't it, Dorianne, that the outcome measures are so important. So
Absolutely.
That if you're a clinic and you're able to provide good outcomes,
yeah.
and you have more patients than episodes of care, or more episodes of care than episodes of care, you've got a huge community need, then you're going to be communicating that with your LIN, and the ministry is going to be seeing that you're giving good results. And it may be that in future years there are more episodes of care available.
Yeah, I think it's just important to know that this is, again, it's a new system. They've done estimates as to what the volumes of services will be. And if you've managed it well and you're in the last quarter, start off with a conversation with your ministry contact first.
Thank you. We are coming close to the end. We're not quite at the end yet. So I do want to take the opportunity to ask people to once again do the poll question. And it'll appear on your screen shortly. So we really do value your feedback. This will help us very much as we plan the next couple of webinars that we're doing. And I know that we have time for at least one more question, even though there are several in the queue. But I'm going to give it back to Roberta to ask either the last or second last question. We'll see how it goes.
So Jen, I'm wondering if you can give this one a shot. The physiotherapist has asked, is it possible that an episode of care could consist of an assessment, one treatment session, and a final follow-up, and still be funded at the $312?
So technically, absolutely. If you have no maximum number of visits and no minimum number of visits within that episode, certainly. What you need to decide, obviously, as a clinician is what the best course of treatment for that particular patient presenting in your clinic at that particular time is. They have a referral from their nurse practitioner or their physician for physiotherapy services, and you need to determine what the best course of action for them is.
So basically, if the best course of action is an assessment, a follow-up visit, maybe 1 or 2 or 3 visits, then that's the best episode of care that you can provide based on the care that's needed.
Totally best for the patient. She got better.
That's right.
And we've got a couple of questions that are asking for clarification on something. I know we've talked about it a couple of times, but it is popping up a couple of times. And the question is, can you limit the number of sessions in an episode of care?
No, you can't. Were you asking me? Because I just jumped right in there.
Actually, we did have your name beside that question.
I guess it was my
It was
ESP.
mental telepathy.
So you can't. And yet I understand that sounds unreasonable. But it comes back to what Dorianne talked about earlier, I think it was Dorianne, that we need to rethink how I'm not a PT, you need to think how you manage patients. If somebody needs, so my 3 episodes of care before you resolved, 3 visits and then you resolved my episode care, leaves a nice surplus of 9 for Dorianne's treatment the next time she presents to you. And so the funding model is shrinking and expanding based on patient needs. If I need many more treatments than that, then it's starting to sound like a chronic problem, and it's starting to sound like a different patient management situation where you're treating flare-ups and relying on other resources to manage in between the flare-ups. But because I'm no PT, I'm going to ask Shelley and Dorianne to confirm that would be the approach they'd take.
Yeah, I agree with what you're saying. I think you can't presume ahead of time and apply a 12-visit model before you've assessed the patient. So to communicate that to patients that, you get 12 visits without knowing what that particular patient needs, I would agree with what Shenda was saying. You have to look at the patient's need, and some will only need a few visits, and some may need several more.
I think the other component to the answer to that question is it's not so much looking at whether you have a 12-visit limit per episode of care. You might look at the funding model and look at and say, on the average, just looking at on the average, I can do about 12 visits as an average number of visits. let's say that's, you know, looking at your bit, but that's what your conversation that you're having as a business person, or as a looking at how you're going to manage your clinic. That's not a limit you're imposing on individual patients. You take that conversation about, you know, on the average it's going to be about 12 visits, because that's about how much it takes for people to get through on the average. Some will be less, some will be more. And then you also look at how you deliver services. So if you think that on the average it's about 12 visits, then do I front end load my visits and then decrease the amount of frequency and extend it over a period of time so that I can appropriately transition them to self-management or other programs? It's really on how you look at it differently. So no, it's not a 12 visit limit, but there are conversations about how do I deliver services and how do I develop my programs that can take that into consideration as an average.
Great. Thanks very much, Dorian. We're now out of time in our webinar, but before we go, I just wanted to clarify that if you did the poll at the beginning of the session, we'd like to ask that you do the poll again before you disconnect. So thank you very much for attending. If you joined late, an archived version will be posted to the websites of both the OPA and the college. And we also wanted to remind you that our next webinar topic will be on applying the funding model in long-term care. Please watch our websites for scheduling details.
Thank you.